So, good afternoon, everyone, and welcome to this new edition of the GSMH Webinar Series organized by the Global Society of Medicine and Health. My name is Arman Mahdavi. I'm the president founder of GSMH, and I'm truly glad to see as many of you here this afternoon and hope some more will join. Oh, they're just joining right now. The purpose of this webinar is simple: to connect medical students and doctors worldwide, to learn from each other's experiences, and to open new paths to our future career. Tonight, we have the pleasure to welcome Dr. Georgiana Constantinescu, MD, PhD, endocrinologist, and lecturer at Grigore Popa University of Medicine and Pharmacy in Iași, in Romania, and a clinician-scientist in Dresden, in Germany, who will share with us her expertise on plasma steroidomics for diagnostic of primary aldosteronism. The session will last about 30 to 45 minutes, followed by a Q&A, so feel free to raise your hand or use the chat to ask your question at the end. Once again, thank you for joining, and thank you, Dr. Constantinescu, for being with us today. Before we begin, I'd like to give the floor to Marwan Dahoud Mahmoud Jaber, our GSMH Georgian branch director, who will officially open the session.
Yeah, hello everyone. So thank you for having me here. Thank you, Arman. Dr. Georgiana Constantinescu. Sorry if I'm saying it wrong, doctor. But yeah, she's an endocrinologist and a lecturer with strong interest in clinical and translational endocrinology. She completed her PhD on adrenal hypertension in Dresden, Germany, and holds a master's degree in clinical research from Dresden International University. So her academic work focuses on improving the diagnosis of endocrine hypertension through advanced steroid profiling and machine learning. Passionate about teaching and mentoring the next generation of students and residents. She is currently teaching at Grigore Popa University in Lazio, Romania. So she aims to inspire students to connect scientific understanding with the clinical reasoning and innovation in patient healthcare. Doctor, thank you for being here and for joining us. The floor is all yours.
Thank you very much for having me here and for your invitation. I will be really excited to share some of my research and some of my results with you today. Can you see my screen now?
Yes.
Okay, great. So most of the work focuses on what I've done while I was a PhD student in Germany. A little bit on my background. I started my residency in Romania, in Iași. I've done some exchange internships while I was a student and while I was an intern over here in France. And after this, I went for my PhD in Germany, where I worked with two really actually legendary professors. And I had a defense in Germany and then back there in Romania. And these two professors that I really admire a lot were the ones that developed some techniques to diagnose tumors that produce catecholamines in excess. And these techniques have actually proven to be so sensitive and specific that they are now the main techniques that we are using for measuring metanephrines, and they also worked on the guidelines for diagnosis these pathologies. Over there, I was an investigator for a study that focused actually a little bit more on primary aldo, but I also have seen a lot of patients that had pheochromocytomas, paragangliomas, other types of adrenal tumors, or any forms or suspicion of secondary hypertension. And together with colleagues, we've put together a unit called an adrenal center over there. So my objective today would be to share with you a little bit about primary aldo, tell you how can steroids help in the diagnosis of this disease and how we can integrate it in clinical practice, as well as some pitfalls and limitations. And this disease is characterized actually by an excess of aldosterone that is produced in the outer layer of the adrenal. And unfortunately, this excess of aldosterone has an impact not only on the heart, not only cardiovascular, but also metabolically. And these patients suffer frequently from diabetes. They can also have renal damage, neurological complications, and frequently also depression and anxiety. The problem is that despite all of these metabolic complications and the cardiovascular ones, it is still diagnosed only in 4 to 12% in the primary care centers. And this is mainly because this disease is not really, clinicians are not aware of this disease. And there are also many difficulties in the diagnosis. And the current diagnosis looks pretty much like this road in Romania. It's really tricky and it's really windy. So it makes clinicians be not that motivated to search this in the patients. And this is the latest guideline, and you can see there are a lot of lines, a lot of values, a lot of cutoffs. So most of general practitioners, when they see so many limitations, they tend to restrict their diagnosis. And usually we measure this aldosterone to renin ratio, and we have to take into considerations a lot of drugs to look if the patients are under beta blockers. We have to take into considerations if they're under other medications, is the result falsely negative, and then we have to retest patients again. After we finish with this entire process, we should know if patient has a surgical equilibrium PA, and this is relevant because these patients usually have an adenoma and they can really profit from the surgery. This means that after they get operated, most of these patients do not have hyperkalemia. They do not have so many antihypertensive drugs as they did before, while patients that have the non-surgically curable PA, they present with micronodules or diffuse hyperplasia, and these patients could not benefit from surgery. So it is essential to identify between the two forms of primary aldo in order to proceed with proper care. Again, the guideline tells us if the patients have a high probability, a low probability of having this type of lateralized PA, or intermediate one. And depending on this type of probability, again, we should proceed with other suppression testing if there's an intermediate probability, or with direct imaging if there's a high probability of lateralized PA, and then continue with adrenal venous sampling. This is a procedure where blood is drawn from the adrenal veins in order to see if there's one side with an increased concentration, a dominant aldosterone concentration, then we know that this side should be operated. So as you can see, again, there are a lot of different directions that patients have to undergo and different diagnostic steps that clinicians have to undergo. So what we also know is that patients that have one single nodule, they frequently have a mutation. And this mutation is somatic, and one of the most frequent mutation is in a potassium channel. And what is particular about this mutation is that patients have an increased concentration of substeroids that we call them hybrid, because they usually are not in this glomerulosa zone, they're in the fasciculata, and this hybrid steroids can be even 20 times higher than in patients that do not have this mutation. So this is really something typical for patients with one single adenoma. And as I said, normally we don't have this secretion, and in patients that have these tumors, they would produce from 11-deoxycortisol from the fasciculata, this hybrid steroids 18-oxo and 18-hydroxycortisol. Good. Now I'm going to share with you how can we bring all of this together to help patients skip some of these steps. There's a really sensitive and specific technique called liquid chromatography. In this steroid profile, there's a combination of different steroids, and we currently have heard a lot about machine learning and how can machine learning help diagnose patients. And REDCap is a platform where data can be put in and also retrieved later on. A couple of words about machine learning. This is actually a very useful technique because it combines analysis of a lot of data that are coming from different dimensions that are not necessarily linear. And machine learning can help identify some patterns and some relationships that to our eye and to doctors are not obvious. And the advantage is that it goes beyond a cutoff or a number, and it can identify this stronger or weaker relationship between different combinations of features. And on the right side, you can see some of this machine learning for diagnosing PA with different combinations of steroids. And these are different models that have been used in this manuscript. A steroid profile is actually a long list of hormones that are produced by the adrenal. You have on the top row mineralocorticoids, then there are glucocorticoids over here, and androgens on the back part of it. And the steroid profile over here has reference intervals that are adjusted to the sex and the age of the patient that has been investigated. And the mass spectrometry is a very good tool because it can measure really sensitive and specific without interferences like immunometry. And it has already proven to be efficient in differentiating patients that have Cushing's, that have ectopic Cushing's, or have adrenal Cushing's. And we are now trying to look a little bit deeper, how can it help in primary aldosteronism? What's important to know is this entire machine learning studies, they need a couple of phases in order to be reliable. First of all, the data that you input when you proceed with the machine learning algorithm, it has to be really good quality data. There's also a saying that garbage in, garbage out, meaning that if you bring poor data, your results will also be poor. What it means that the data that you extract, it has to be prepared. It has to be corrected for confounding factors. It has to be normalized. There's even differences in the batches that are analyzed in the mass spectrometry. And after pursuing this phase, usually patients are split into a training phase where the algorithm that have been found to be the most, let's say they have the best score for accuracy and sensitivity. They're trained on a group of patients, which is mostly like 80% of the lot, multiple times. And after finding and doing this training, these are validated on a new cohort of patients. Now let me show you practically what this means. I've seen this patient while I was in the unit over there. She was hypertensive with poorly controlled blood pressure. You can see here on the 24-hour monitoring was not well controlled. She did not have a deeping in the night. And she also presented actually a potassium that was in the lower range. And this was despite antihypertensive therapy with even a mineralocorticoid receptor antagonist. You can see here she had 4 antihypertensives. She also had the supplementation for autoimmune thyroiditis. And despite being pretty correct with her treatment, she still had high blood pressure. So she was suspected of a secondary cause of hypertension. And this patient was enrolled in the study called PROSALDO, where we looked at the genotype, at the genetic results of the adenomas after they were operated, and at the blood results from these patients. And we wanted to see, okay, can this steroid profile predict and find the patients that had this type of mutation so that we could skip this entire procedures. And this was an international trial that we started a couple of years ago, and we enrolled a lot of patients, more than 1,000 patients. And let me just briefly show you how it went. This patient had this normal aldosterone-renin ratio that normal guidelines suggest and has to be done for screening. But besides doing this, we also had this steroid profile. And they underwent all of the normal procedures like screening and then confirmation and then subtyping. But each time they went into a different procedure, they also had this steroid profiling together. And we found the steroid profiling that was not normal in the screening phase. They would go to the next confirmatory phase. If again the saline infusion test, the confirmation test was not normal and PA was confirmed, patients would undergo this catheterization of the adrenal to see if the disease was one-sided or both-sided. But again, this was done together with the steroid profiling. In the end, the patients underwent, if they had PA, either adrenalectomy or they underwent a mineralocorticoid receptor treatment. And they had to come back 6 or 12 months later to check on them again after the therapeutic intervention. Good. So after we performed all of this step in this patient, again, this was a female patient. This patient, we noticed that she had an increased concentration of this hybrid steroids. You can see here 18-oxo and 18-hydroxycortisol. It was higher than normal average for patients in this age and gender, and there were no difference in the other steroids. And the different models, linear discriminant analysis, support vector machine, and random forest, these models, they show the high probability of having primary aldosteronism, and the mean probability was around 80%. So what I meant to tell you, having this high probability, the patient underwent further diagnosis. And again, you can see here there was increased concentration, and the patient did not have a value that decreased after 4 hours after the infusion test. And again, the hybrid steroids, you can see they did not increase. Aldosterone even got higher after the infusion. So this supported the idea of primary aldosteronism in this case. She also underwent this catheterization in order to see if there's a lateralization. And indeed, there was a lateralization in this patient on the right adrenal. And this was also the site that she presented with the tumor on the CT scan. Further on, she was operated, right adrenalectomy. She had this mass, this adenoma that was positive for the enzyme typically synthesizing aldosterone, and she presented this mutation that I previously told you about in this potassium channel. So this supported the idea that indeed these patients have increased hybrid steroids and they would have these tumors. Another problem that we encounter when we do this entire diagnostic is how do we deal with medication, with antihypertensive medication? Because actually most of the drugs we give for hypertension, they interact with the aldosterone, with the renin-angiotensin-aldosterone system. And the problem is that most of these drugs, they will increase renin, and through the increase of renin, this aldosterone and renin ratio would be falsely decreased. And the only exception is actually our beta blockers that are suppressing the secretion from the juxtaglomerular cells. So this would lead to a decreased renin and to a false positive aldosterone-renin ratio. Again, I want to show you with a clinical example. This was a patient that was hypertensive, but he also associated hypokalemia. He had an adrenal mass and high blood pressure, and he was aggressively treated for his high blood pressure with high dosage of spironolactone. And despite this, he still had hypokalemia and he needed supplementation. And he also had a calcium channel blocker and a central blocker, and you can still see that his blood pressure was not perfectly controlled. So when you look at this patient, you can see already from the clinical data and from his blood pressure that he is really of high suspicion of primary aldosteronism, especially since his hypokalemia is not getting corrected with spironolactone. Despite this, when we did the lab results, okay, we would expect really high aldosterone, but the renin was also high under spironolactone. So theoretically, the guidelines, they also suggest we have to stop spironolactone in this case and do measurements of aldosterone and renin again. And you can see this time aldosterone doubled and renin got this time suppressed. And this made the aldosterone to renin ratio that was initially falsely negative, it proved to be positive. We had to give him even more potassium since we stopped the spironolactone. So this is actually a clear-cut case of primary aldosteronism. When we looked in this patient at the steroid profile, you can see the initial steroid profile, it was surprisingly did not have a very high aldosterone, not above the upper cutoff. The hybrid steroids were, however, increased. And when we looked at this probability of having primary aldo, it was really high. After stopping the medication and putting him on non-interfering drugs, you can see he maintained this high probability of having PA, and this time aldosterone raised, and also glucocorticoids also got increased after stopping this medication. So it made a difference for the steroid profile, but for the analysis with the machine learning, it was the same increased probability. So the hypothesis of this another study that I've done was maybe the steroid profiles could impact less than the normal aldosterone to renin ratio. So we took a look at almost 200 patients with PA and over 500 that did not have PA. And you can see they were pretty similar from the baseline characteristics. And of course, patients with PA had higher aldosterone, 18-oxo, the hybrid steroids, higher probability scores of having PA, a suppressed renin, and a positive aldosterone to renin ratio. These patients were diagnosed and also checked how was their status after the surgery. And this is a criteria called PASO criteria. And we also looked at the immunohistochemistry of aldosterone in these adenomas. And for patients under treatment, we took a look later on and performed another saline infusion test to be really sure of the diagnosis. And we've performed a couple of statistical analyses and look actually at the ROC curve, so at this receiver operating characteristic to look at the sensitivity of specificity of the two types of analysis. And what we've seen when we looked at patients, so we've done a paired analysis, was the same patient with clean medication and with interfering medication at the beginning. And we've also done with a multivariable analysis. That means we've left also the entire medication when we did the analysis. So when we looked at the mineralocorticoid receptor antagonists in patients with PA, what we actually noticed is that, as expected, they increased a lot by 150% more than that renin. And by increasing renin that much, they decreased actually this ratio. And even when we looked at patients that were only on the drug, we noticed the same pattern. So the main take-home idea is that this drug should be avoided even in patients with in all patients that are screened for primary aldosteronism. When we looked at ACE inhibitors in patients with PA, you also notice that expected renin would increase in these cases, and aldosterone also had a tendency to decrease in these patients due to, of course, increase of renin. So these patients presented with a false negative. In patients with PA, there was not that much of significant other types of medication. So current guidelines also support diagnostic under calcium channel blockers, under diuretics, and that patients should be screened even if they have interfering medications, and we should try to interpret the aldosterone renin ratio under current medication in order not to make it very difficult for the patients and for the clinicians to have a different type of screening with and without interfering medication. The idea would be that the MRA would decrease aldosterone renin ratio in a high percentage of patients, even higher percentage ACE inhibitors and angiotensin renin blocker. It also had a difference in a patient that initially had a really low ratio and afterwards it decreased to 500. So really sky high difference between them. When we look at beta blockers, as previously mentioned, they reduce renin, so patients would have a false positive aldosterone to renin ratio. In patients without PA, they would have frequently this positive aldosterone and renin ratio because of this. So multivariable analysis also was performed together with paired analysis in patients that did not have PA, and in these cases, spironolactone increases everything. So these patients would have high renin, high aldosterone, and also hybrid steroids, and this is why spironolactone or eplerenone, if it's the case, they should be stopped when performing this investigation, and even steroid profiles are influenced by these drugs. So this is an area under the curve that analyzes the sensitivity and specificity. And these are patients that did not have interfering medication, and this is with interfering medication. And when you look at this ratio, you can see that patients with non-interfering, they had a better area under the curve. This shows that the aldosterone and renin ratio is actually affected by medication that interferes with it. When you looked at the steroid probability scores, you can see there's not actually a very big difference. There's not even statistically a high difference between this area under the curve. They are also, both of them, pretty good for interpreting. And when we look at this, when we compare the two of them in patients that have interfering medication, so we did not stop, and you can see that clearly the steroid profile performs better. So this could be a tool in patients that could not have their medication changed, that they have really high cardiovascular risk, or they have developed complications when medication was tried to be switched. This could really be good opportunity, this tool. So the message to take home would be that this data is pretty unique and it could help see better, okay, how do different medications influence steroids? And this ratio is influenced overall by drugs, and this impacts the aldosterone to renin ratio, and the steroid perform has a better performance. We should try to avoid MRAs because makes a lot of false negative ratio. So if patients are under spironolactone, you could say, okay, there's no PA because this renin is so high, like the patient that I've shown you. And maybe in some cases where there's really hyperkalemia and there's a really high probability of PA, this could mask the primary aldo, so patients should stop it. On the other hand, beta blockers can have really false positive because of this suppression, but it impacts minimally the aldosterone concentration. And AC inhibitors and angiotensin receptor blockers, they can cause this low false negative ratio, and it was actually inconsistent on the steroid profile, the different results. And the hydropyridine channel, calcium channel blockers, they can actually be used because they have no interference. And for the diuretics, we actually did not have a lot of information, but they increased some of the hybrid steroids. Okay, there's a really large team behind a lot of this data and a lot of the work, so I have to acknowledge them and thank you very much for your attention. If you have any questions, I'm here to answer them. Thank you.
Thank you, Doctor, for this amazing lecture. I have a few comments that I want to say, but first, let's hear if anyone has any questions. And so, yeah, guys, they're all saying thank you. If anyone has any question, please go ahead, raise your hand and speak.
I hope it was not too much detail. Can be overwhelming.
Yeah, guys, like don't be shy. Like this is an open and friendly space to exchange ideas and learn from Doctor. Until like if anyone has any question, I wanted to say that your presentation and presenting skills are really amazing. I really thank you for this. I mean, it's truly amazing how you do this. Hopefully, I can get to this level one day, and I think Arman also would agree. That's what he told me also.
Thank you very much. That's
Yeah,
very kind of you.
Of course, no
yeah,
problem.
it's very nice and very insane, and we are very proud and very happy to have her as our teacher also in endocrinology in our university. So that's very, very nice.
I
Thank you,
would say
Arman.
lucky you guys.
Exactly. Doctor, I will ask you one question that will probably like give more information for them. Because you're both clinician and researcher, what do you think like young doctors, students should focus on if they want to bridge the gap between clinical endocrinology or any other specialty and transitional research like yours?
Yeah, that's a very good question. What they should do, I think, they should start focusing on something that they're passionate about while they're still students, because I think it's really hard when you start training as a resident to perform any type of research when you're doing night shifts and night calls. So you have to have some spare time for research, and it's going to be more difficult to develop it later. So I would encourage everyone to start working on a small project or something that they're passionate about in a subject they want to find out more while they're still students. And if there's a lab or someone available doing research, even maybe it's not the best subject, just to gain a little bit of insight, what they're doing, how they're doing, to be there. And you can switch maybe the subject later on. But I remember I wanted to learn something from microbiology because there was the only lab while I was a student that they were doing some special analysis, and just went there to ask them if they could show me so I could have a skill. So any skill I think in research is a good one to gain while you are a student.
Thank you, doctor. And at the same time, what are the most important skills that you need as like a researcher and also clinician to be able to produce this quality content in research?
Uh, I think it's perseverance and not giving up. Was really, I had the opportunity to work with these amazing people and mentors, and they were pushing me a lot, and I just enjoyed it, and I didn't give up. So I have to be honest, it's a lot the merit of the mentors, because if you work together with people that are passionate, I think you're going to develop this passion and interest to find a team that you like and that you enjoy, and to work with people that are fascinated about their job. And this could also encourage you to do the work.
Okay, okay, thank you, Dr. Marwan. Do you have any question or should I continue because I have some?
I will ask after you finish. Go ahead.
How did you get to at the end choose endocrinology, and what was the turning point that made you choose to go in research side of endocrinology?
I actually chose this subject because I was fascinated about the entire mechanism, and I thought it was really logic and clear, and it was a good specialty um, to combine different types of knowledge. And this is what I also enjoyed it. It was not so linear. It also involved genetics and radiology and other specialties, and work together in a team. And research, I was always actually pretty passionate and interested in doing more than the clinics and trying to help patients in other directions. So I think it just suited my initiative to do a little bit more for the patients and try to improve and progress with the diagnosis. And having the opportunity to meet this professor, I actually ended up in Germany after meeting a professor in a conference where I held a presentation, and he confessed that he was impressed more by my motivation and my presentation skill than the quality of the presentation, because we didn't have that good data. But he asked me if I wanted to do the PhD because he just saw that I was motivated. So I think this would be another, be motivated into something that you really like.
Okay, thank you, Dr. Marwan. Your turn.
So yeah, I just came up with a question actually I had in mind. Since like in many fields there we can also do this type of clinical research, and I was also interested in maybe later doing, I think it's a master's in machine learning. It's a master's, right? Or a PhD?
I've done a PhD, but I work together with people. I'm now doing a master's in digitalization and informatics
Mhm.
and interoperability, but I had no knowledge at that point. I work together with people in this field. What you have to be open to is also learn new skills
Mhm.
and new technology. And I think nowadays we all need to learn more about AI and how we can use it in our
Mhm.
daily practice, because it's evolving so much in all types of diagnosis.
Yeah, so I was like interested in doing that later, and for now, I was like maybe I should lean towards learn how to do analysis, basic analysis. Do you think like anything else beside like learning about AI analysis that can help further to get into this master's or this PhD?
hmm I think any knowledge of statistics is good knowledge, and unfortunately, some of at least my university they did not provide that much. What's good now is that knowledge is available a lot more than it used to be, so you can learn. And I also did learn a lot from YouTube using different types of softwares and how can I do types of basic statistical analysis. So that would be one recommendation, start learning from YouTube and anything that it's free more about it. And afterwards, check for opportunities of different masters or PhDs. They usually search for people that have some basic knowledge. In Germany, I was lucky that this position was for clinicians, that they had some point from their clinics just to do research, but usually you don't get this opportunity. You either do research for 2 or 3 years or you just do clinics. You can't do both of them. But for me, that was a good position because they had this open. Otherwise, you really have to focus 2 years or 3 years to do lab. I've tried lab, but I would see patients and do lab, so the cells would die. So that's difficult. You have to either do one or, yeah, both of them. It's pretty, you have to be really skillful.
Oh, that's really amazing. I mean, based on everything that you have done and all of this amazing stuff, what's like your future steps, if I can say, in these fields?
Yeah, that's a good question. So now I came back to my university in Romania, and I'm trying to build also here some of the things that I've learned over there to have an adrenal unit to start doing this liquid chromatography, mass spectrometry type of analysis, because there's a facility where you can do it and get some money, some financing to do some of the research. I'm still working with my colleagues over there, and we're still collaborating on projects. So the idea would be to build something in the place that I came from.
Oh, okay. Really amazing. I mean, I wish you the best and hopefully you
Thank
can
you.
grow further and further in this field. It's really amazing.
Thank
Um,
you so much.
One last thing, doctor, I wanted to ask you, and it's gonna also help us to for the next upcoming webinars that are coming. I don't want you to like spread a lot of information on it because it's a very big and wide subject, obviously. Now that you're working with AI and data interpretation, what is the future place of AI in our daily job as a doctor?
I think more and more tools are now developed and they are actually being used in some patients. Of course, we need prospective studies to see that they are really working. But I believe one, we should get to learn more about it in our lectures at the university to have students another subject where they get prepared. How do you analyze data with AI? How can I write a good prompt? What kind of data should I give about the patients? But it would definitely become routine in the clinics at some point. It would help a lot to automate some of the processes we're doing and support clinicians in some diagnostic. I don't believe it will ever take from the decisions the doctors are supposed to have, but they can really support us in some of the decision.
Thank you, doctor. Thank you for your time. Marwan, anyone has any
Uh,
question?
yeah, I want to say, Doctor, I once heard a colleague that's saying that we really need to appreciate other fields than medicine, like physics, technology, because they all can help in medicine. You agree with that? I think you most have seen all of this collaboration between many fields into getting the patient just better.
Yeah, definitely. And I've also had colleagues in Germany that they could code and they wrote very good projects and applications for patients and professors in AI in medicine that are now doing some amazing work in identifying patients that are at risk of metastatic type of cancers and the answers and what would be the best medication. So things are really evolving and we need new skills besides being really good clinicians. Yeah, definitely. Your friend is right.
Okay, so like if anyone has any other question, like you can ask it. If not, thank you so much, Dr.
Excuse me, I have a question.
Yeah,
Yeah.
go on.
Uh, Let me start by saying thank you for your presentation today, doctor. It was amazing work, and we all appreciate it. But I have one question, which is like not related to that. I just have a question that how, like, or what's the reason that a person could have hyperthyroidism?
Thyroidism.
Yeah, hypothyroidism.
Okay, it can be different causes. It can be mostly it's an autoimmune disease. It can be autoimmune thyroiditis. It's like Graves' disease. So antibodies that are for TSH receptor on the thyroid, they get overstimulated and they produce a lot of hormones. Then there can be a nodule over there, an adenoma that produces excessive thyroid hormones. Then you can also have an infection that can determine only on a short term an destruction of the thyroid. And at that point, there's only thyroid toxicosis, it's called. It's only a liberation of a lot of thyroid hormone. It's not a constant overproduction. And there can also be multiple nodules that can determine this. So it depends, but there are mostly Graves would be like the first, and then there's an autonomous nodule over there.
So is it curable, or you have to just manage it by taking medicine?
No, you need drugs or you need surgery, depending on the cause of it. But there it can also be transitory. It depends. So you need a little bit more context. You need some antibodies, ultrasounds, a little bit more investigations to find out what would be the appropriate therapy.
And like, what are the symptoms of it?
You would lose weight, you would be really anxious and nervous, you can lose hair, you can have a lot of sweating, have palpitations, your heart would be going really fast, would be really nervous, have trouble sleeping. This would be some
Oh,
of the signs.
okay. Thank you
Yeah,
so much again.
you're welcome. Good.
So anyone else? I think not, maybe not. So again, thank you, Dr. Georgina Constantinescu, for your very inspiring, truly inspiring and insightful session. And thank you everyone to join us today. It's always inspiring to see medical students and doctors for different countries connecting, learning, and sharing knowledge together. That's exactly what we're aiming for with the Global Society of Medicine and Health. We hope this discussion helped you better understanding the primary aldosteronism and plasma steroidomics, how is shaping the future of endocrine diagnosis and research, and maybe inspire some of you to explore this fascinating field further and also this specialty. A special thank you to Marwan for being with us today and for his continuous dedication and support within GSMH. Always your efforts are truly helping us and helping this initiative to grow and reach more students around the world. Don't
Thank you.
forget, thank you. Don't forget to follow us on LinkedIn, Instagram, and check the link in our bio to register for our next upcoming webinars. Once again, thank you everyone for being part of this growing global community. And thank you, Dr. Constantinescu, for your time and generosity. Have a
Very
great
nice. Thank you for
afternoon.
having me.
Thank
Have a
you.
nice afternoon.
Have a great afternoon,
Thank you.
everyone.
Bye.
Bye bye.
Bye.